All right, this is part 2 of your cardiac lecture, looking at cardiac output and how we can control what your heart is pumping out. So first, just a definition on your cardiac output, which is how much blood is being pumped out by each ventricle per minute, right? So there are different factors that affect how much blood your pumps out per minute. And those include your nervous system. So remember, cardiac muscle is controlled by the autonomic nervous system, both parasympathetic and sympathetic fibers. Changes in your heart rate. The faster your heart pumps, right? This is how fast it goes. The faster it pumps, the more you put out per minute. Factors affecting cardiac output, also the stroke volume. So we'll look at stroke volume. So that's how much, that's the volume that's leaving the heart, is the stroke volume. So how fast your heart is contracting, how much each contraction pushes out, that's going to take, those two factors are going to be involved in overall cardiac output, right? So these are the two big factors, your heart rate and your stroke volume. So this is the overall flow chart. We're only going to look at a couple of these or a few of these factors. But let's just take a look at our cardiac output on the bottom, right? So this is how much blood our heart ejects per minute. And it's controlled by two factors, the heart rate multiplied by the stroke volume, right? So this is how fast our heart pumps, and this is how much it pumps out. Looking at the heart rate, how fast your heart beats, this is going to be due to a few different factors. We're going to look at autonomic innervation, so this is your parasympathetic and sympathetic fibers. We'll look at some hormones, but also what comes into play here is fitness levels, right, and your age. So those are variables. Looking at the stroke volume side, the stroke volume, remember, is the amount that leaves the ventricle. So it is the end diastolic volume, which is the fullest that your ventricle can get, minus the end systolic volume. This is I'm going to put empty in quotes because it's not really empty. There's some blood left over, right? So whatever leaves the heart, that's your stroke volume. And that stroke volume has many different factors. So we can look at the size of the heart, the fitness levels. We talked about how Lance Armstrong, actually that was the heart rate, but yeah, fitness level affects that too. The gender can affect that, but we're going to look at contractility, which means how forcefully your heart muscle contracts, right? And that's going to be controlled by both the autonomic nervous system and also hormones. So the force of contraction. We're not going to look at duration of contraction, but that is a factor. And then there's the preload. So what that is end diastolic volume. So this is also called preload. And then also something called afterload. So let's get started by looking at just the autonomic innervation to the heart. So you probably remember that the parasympathetic fibers, the rest and digest, is going to your viscera through the vagus nerve. So this is your main delivery method of parasympathetic messages to your thoracic viscera, your abdominal viscera, and the vagus nerve is your, basically this is called the now I forgot that saying, rest and digest. Rest and digest. So very calm. And you can see the fibers are innervating the SA node and the AV node. So the vagus nerve only goes to your nodes. The sympathetic fibers travel differently. So it's not through just one network, one nerve like the vagus nerve. It's through different methods, but the sympathetic nerve fibers are going to innervate the nodes, SA node, AV node, but also it comes to the ventricular myocardium. So it has a role in innervating separately the myocardium of your ventricles, and that will help to contract the heart muscles more forcefully so that you can get more stroke volume. So we have sympathetic fibers, of course, will speed up your heart rate. Your parasympathetic fibers, basically the vagus nerve, will slow down the heart rate. All right, so let's take a look at your sympathetic fibers changes first. Before we get to that, just a quick, looking at letter C in cardiac output, that your heart rate is determined by your SA node firing. So when we talk about heart rate, right, this is the speed of your heart. And that is going to be based on SA node, right? Because we know the SA node is going to be your pacemaker. So you want to tell your pacemaker to pick up the pace. And if the SA node was on its own, it could fire up to 100 beats per minute. And that's super, super fast. So if there's no extrinsic control in the heart, your heart rate's 100. Your SA node is always under this autonomic control. It's under the control of hormones because you're always going to have hormones throughout the body. And so at rest, your parasympathetic fibers are going to win, right? They're going to dominate, and they're going to have a heart rate around 75. And then if you're excited, then the sympathetic fibers take over, and then your heart rate will increase. So what we're looking at is changes in the SA node in the pacemaker, right? So how does that happen? Well, this is the flow chart. So we are going to either have nerves directly synapse with our SA node, and that the neurotransmitter that's secreted is epinephrine, or you can have epinephrine in the body as a hormone, right? Because that's produced by your adrenal glands. They are going to interact with beta 1. These are adrenergic receptors, right? Adrenergic receptors in the SA node. And they're going to increase the open state of your funny channels. This IF is the abbreviation for funny, right? We looked at funny channels in the pacemaker cells, the physiology of conducting an action potential. So remember, funny channels are going to allow sodium in. And that sodium coming in will make that internal cell positive enough that the calcium channels will also open, driving even more positive towards action potential. So if you keep increasing the openness of your funny channels, you're going to increase the rate of your spontaneous depolarization and increase the heart rate. So this is the flow chart, right? So this is your norepinephrine or epinephrine. This is your beta 1 adrenergic receptor. This is a G protein coupled receptor. And the flow should look very familiar to you, right? Our G protein is going to activate adenylate cyclase. Adenylate cyclase is going to break down ATP to make cyclic AMP. The cyclic AMP is going to activate our protein kinase, and kinases, what they do is they phosphorylate. And this is going to phosphorylate and activate our funny channel, which is going to increase our sodium coming in. This increase of sodium coming in will also increase the amount of calcium coming in. Both of these positive charges leading to depolarization and SA node firing. So the more of this happening, the more of the secondary messenger pathway happens, and then the more positive those cells will be, and you get more depolarization. So that is how the sympathetic nervous system works to increase your heart rate, by increasing the depolarization of your SA nodes. Looking at the parasympathetic, right? If you increase your parasympathetic activity, which is your vagus nerve, the vagus nerve sends out acetylcholine. So the acetylcholine is going to act on muscarinic cholinergic receptors. Remember, these are slow. So this is ACH. G protein coupled receptors as well, also in the SA node. And if you think about slowing down something, right, we want to mitigate or minimize the depolarization, right? So you want to do a hyperpolarization. You want to drive that membrane a little bit lower, more negative. So what you're going to do is you're going to increase potassium channels, right? Potassium channels tend to leave the cell. And you're also going to close those calcium channels. So let's take a look at the picture. So here's our acetylcholine, right? Here's our muscarinic cholinergic receptor. Here's our 2 G proteins. So there's 2 things happening, right? Number 1, we get to open our potassium channels. So we get hyperpolarization, potassium leaves, making the inside more negative. We also stop, right? We're going to close our calcium channels so that our positive charges don't come in. So we create a more negative internal environment. So that's going to hyperpolarize our cell and make it more difficult for a heartbeat to happen. It's not going to completely stop it, of course, because you'll die, but it decreases the heart rate. It decreases the amount of spontaneous depolarization. All right, other things before we get to that, just in your notes, we have hormones. So insulin, glucagon, thyroid hormone, epinephrine, these all mediate heart rate in different ways. But the same kind of mechanism where you either increase or decrease the heart rate at the SA node. And then just a word on emotional stress. We know that the limbic system of the brain can impact your heart rate. And so in times of stress, you can have higher than normal heart rates. And this can be due to both cortisol as well as the sympathetic fibers firing. So both of those elicited by emotional responses can lead to rapid heartbeats. It can lead to a heart attack if you are prone to heart attack, if you're an older person. And most of the time it's transient, right? Or, you might get fluttering or some rapid heartbeat, but it goes away. And other times it can lead to a heart attack. So they have shown that breathing exercises activate the vagus nerve. So this slow, deep breathing, can actually activate and stimulate the vagus nerve. And then by increasing the activity of the vagus nerve, you can slow down your heart. So if you're feeling very anxious, you can take slow, deep breaths, which you guys know already, probably. But it's science. It's proven. All right. The other things before I move on is basically nicotine and caffeine. Those are stimulants. And those are going to work in two different ways. Let me just turn to this picture here. So caffeine actually increases the rate of depolarization. So caffeine is going to work right on the SA node. So, and then nicotine works by stimulating the sympathetic neurons. So either way, they're going to stimulate the SA node to depolarize. So caffeine, and nicotine both do this. All right, so let's talk about changes in stroke volume. So now we want to talk about how can we change the amount of blood that's leaving the heart? And there's several ways. I know this is misnumbered here. Sorry about that. Let's take this away. So the ventricles, one is ventricular contractility, how forceful your ventricles contract, right? It will expel more blood the more forceful those contractions are. So that's going to affect how much blood leaves. And the force of contraction, how much those myocytes are contracting, just like skeletal muscle, it's based on how many myosin heads are going to be attached to actin. So what that depends on is increasing our calcium inside the cells. So more calcium that's present, the more myosin heads are able to bind to actin, and the more power strokes can happen. So in order to do that, there's several ways to do that. So we can have sympathetic innervation. And here's that sympathetic activity on the contractility. So again, we have our norepinephrine or epinephrine. We have our secondary messenger system. And then we have our calcium coming into the cell. This is going to allow our calcium channels of our sarcoplasmic reticulum to put calcium into the cytoplasm here. And then that's going to then affect the cross bridge, right? At the same time, we do also have the calcium ATPase pumping calcium back into the sarcoplasmic reticulum. So that works as well, but just, in terms of how forcefully that muscle contracts, it's going to affect the cross bridge formation and cross bridge cycling. So that is number one, ventricular contractility, sympathetic innervation, and then hormonal innervation as well. Epinephrine also binds to those receptors. Other things like thyroid hormone, insulin, glucagon also can increase the force of contraction. So again, nervous system or hormones can have the same effect. So this is just a graph showing you the tension, right? Because we're really talking about, in terms of forceful contraction, we're talking about the tension on the cardiac muscle. And we can see very clearly that at rest, we have a lower peak tension, and then we have sympathetic innervation, we have a higher peak tension. So the higher force, right? The second factor that affects stroke volume is the end diastolic volume. This is also called preload. So what this means is when the ventricles are filling with blood at the end of diastole, can't speak. So your ventricles are now filled to the max, right? They're full. It turns out that when you have, if you look at the graph, there's a relationship between how full the ventricle is and how stretched your sarcomeres are of the cardiac muscle. So if you have, if we look at our first point here, right? So if we have our end diastolic volume, so if we have a smaller volume coming into our ventricles contract, and then the stroke volume is up here, right? That's how much leaves. And this is how our sarcomeres look. So the sarcomeres have a little bit of room to contract, but they're not completely spread out. And then if you stretch that ventricle slightly, you're going to stretch those sarcomeres out. And that's actually a more optimum length to create a more powerful contraction. So you actually get out more volume when you have more blood in it, to a certain extent. Okay, so if you look at the notes, if you read, the law is called Starling's law, right? So within physiological limits, the force of the heart contraction is directly proportional to the length of the muscle fiber. This means that the greater the stretch of the ventricle muscles within limits, the more powerful the contraction is, right? So the greater the stretch, the more powerful the contraction is, which in turn increases your stroke volume, right? Because we have an increase in stroke volume. Therefore, by increasing the preload, by increasing the end diastolic volume, you can actually increase the stroke volume. So the more, basically the short phrase is, the more blood that comes in the heart, the more blood will leave the heart. But this is because the muscle actually contracts more forcefully. And then there's another, our last topic here is afterload. Afterload is the pressure in the arteries pushing back on the ventricles, and it has to work against that blood to push it through. So think about, here's your, I'll just draw a simple heart, right? Here's a very simple heart. Here's your left ventricle. Here's the opening to the aorta, right? So the aorta is going to come around the heart like this. So what afterload is the pressure. So the pressure that falls back onto the semilunar valve there, the aortic valve. And so the blood in the left ventricle has to counteract that pressure, right? Because if we're going to pushing this in this direction, we're going to have to counteract and overcome this afterload. This is called afterload. Okay? So the greater your afterload, if you have more pressure coming down, then you're not going to have as much blood leaving, because that force is, you have to overcome that force. But if you have a smaller, a decrease in afterload or arterial pressure, you can actually push more blood out easier, right? So more blood can leave because it's easier to push the blood out. There's no force opposing you. And that's going to increase your stroke volume. Okay? So that is our third and final factor in terms of what affects stroke volume, right? So this is the overview of that. So we looked at the end diastolic volume. This is how much blood comes in, right? So venous return, how much blood is coming back into your heart. It's going to fill, right? So the end diastolic volume, and that's going to increase stroke volume because our muscles are stretched and the sarcomeres are stretched to their more optimum position. Contractility, which is how forcefully we can contract those muscle cells has to do with, again, just calcium inside the muscle cells, having more myosin heads bind to actin and having a more forceful tension on each muscle cell. And then, again, the arterial pressure or afterload. So that's going to all increase your stroke volume, or having a low arterial pressure, right, will increase your stroke volume. And so let's just go back and look at our big picture all together, right? So again, our cardiac output is affected by both heart rate and stroke volume. Heart rate is determined by, we looked at hormones and the ANS, and then the stroke volume is the contractility, how forcefully those muscle cells can contract. Again, sympathetic fibers and hormones can control that. The EDV or the preload, and then the afterload. So hopefully that makes sense to you, and then both of those will contribute to the overall cardiac output. Last topic that I have before we wrap up is just broken heart syndrome. So extreme stress from something tragic that happened in your life, a death of a loved one, can actually cause heart conditions. And the heart condition is named after, it's called Takotsubo, and it's an octopus trap, because this octopus trap has a rounded region with a narrow neck, and your ventricle begins to look like that. So it balloons out with this narrow neck, and so the left ventricle actually takes on a different shape. And so basically it's a kind of heart failure due to a weakening of the myocardium that's not related to a lack of oxygen, but other things. So the exact etiology, the word etiology is the cause, is not known, but patients do suffer this. So when people die of a broken heart, it's actually, there's this physical manifestation of it, which is interesting, right? All right. Our review for part 2, which is not a factor that increases stroke volume. Okay, so letter D. This factor increases the cardiac output, but not stroke volume. The cardiac cycle consists of a distinct relaxation and contraction phase, which term is typically used to refer to ventricular contraction while no blood is being ejected. This actually belonged in the first part of this lecture, but this is going to be answer D. Most blood enters the ventricles during, and this is going to be atrial diastole. Yes. Cardiac output decreases with decreased stroke volume and heart rate. How do sympathetic and parasympathetic activity act? Okay, so we're going to have increased sympathetic activity, and decreased parasympathetic activity will decrease SV and HR. No, sorry, I have to read through this. Decreased sympathetic and increased parasympathetic will decrease SES. So this is this. So if you decrease your sympathetic activity and you increase your parasympathetic activity, this is going to decrease your stroke volume and it's going to decrease your heart rate.